Hello, today I'll be presenting a poster entitled Addressing Pressure Ulcer Bacteria, Impact of Fluorescence Imaging on Assessment and Treatment. This was part of a large clinical trial done in association with the Serena Group Research Foundation. Pressure ulcers result from prolonged pressure on the skin, and they can affect up to 15% of hospital inpatients and an even larger percent, upwards of 50 in some cases, of long-term care residents. And so obviously this places an enormous burden on these facilities and on the healthcare system. High bacterial loads, specifically of 10 to the 4 colony-forming units per gram, are associated with delayed healing in pressure ulcers and other wounds, and they can lead to infection and other complications. These bacterial loads are typically diagnosed at the bedside by visual assessment of clinical signs and symptoms. However, patients with heavily colonized pressure ulcers may be asymptomatic, creating challenges in diagnosing these wounds properly and therefore managing these wounds appropriately. The MolecuLight IX fluorescence imaging device enables rapid detection of bacterial burden, the presence and location at loads of 10 to the 4 CFU per gram within and around the wounds. This is done through shining a safe violet light over the wound, which the device emits, and this causes fluorescent signals to come back to the device. Many of these colors are filtered out by special filters within the device, and the colors that remain are primarily green, which comes from tissue and specifically matrix components in the tissue, whereas bacteria uniquely fluoresce red or cyan with a very high predictive value. You can see an example pressure ulcer image shown here, the standard image on the left, and then on the right you see regions of red and regions of this bright cyan, which almost appears a glowing white. And those regions were confirmed to be from Staph aureus. And then the cyan color is specific to Pseudomonas aeruginosa. So clinicians are able to determine that a wound has Pseudomonas when they see cyan at the point of care. The objective of this study was to determine the impact of fluorescence imaging on wound assessment, treatment selection, and planning. And this was as part of a multi-center prospective controlled clinical trial on 350 wounds. Today, I'm presenting a sub-analysis of the pressure ulcers in that study. There were 22 of them from multiple sites and multiple clinicians. And each pressure ulcer first was assessed using clinical signs and symptoms assessment, specifically the International Wound Infection Institute checklist. And a wound was deemed positive if more than 3 signs or symptoms were present, or if the clinician felt there was one overwhelming symptom, they could override that 3 and call it clinical signs and symptoms positive. Then the wounds were imaged for fluorescence with the MolecuLight IX, and regions of red or cyan were used to indicate the presence of bacteria at loads above 10 to the 4 CFU per gram. All wounds underwent at least 1 punch biopsy to provide a definitive answer on total bacterial load in that wound. And then clinicians wrote out a complete treatment plan based on clinical signs and symptoms, a complete treatment plan based on fluorescence, and then they indicated how their patient care and treatment selection were impacted. So this study revealed an alarming presence of bacterial burden in pressure ulcers, specifically that 91% of the pressure ulcers in the study had bacterial loads above this level that's known to delay healing at 10 to the 4 CFU per gram. Furthermore, the median bacterial load of the pressure ulcers was 10 to the 6 CFU per gram, and that's a load that is often suggestive of infection. The most common bacterial species was detected as Staph aureus, which is very common across wound studies. Fluorescence imaging greatly improved detection of pressure ulcers with this elevated bacterial burden. Clinical signs and symptoms only identified 2 of the 22 pressure ulcers, despite the alarmingly high bacterial loads, and that yielded a sensitivity of 10%. Whereas fluorescence imaging identified 15 of the 22 with a sensitivity of 75% for identifying these moderate to heavy bacterial loads at the point of care. Here are some example images. On the left, this wound is exhibiting red fluorescence highlighted with the black arrows. This red fluorescence actually looking a little bit yellow because it's combining with the bright green from the tissue. And then the wound on the right illustrates a more pure red fluorescence. Both of these colors are known to be associated with bacteria at above this 10 to the 4 threshold. Now, upon completion of the patient assessment, clinicians did, again, record their treatment plan and complete a survey reporting how fluorescence imaging information impacted the patient's care. And here's what it looked like for the pressure ulcers in this study. Wound assessment was changed in 59% of the pressure ulcers. So clinicians changed their overall assessment of the wound in that high a percentage based on the fluorescence information. An even higher percentage, 82% of wounds, wound bed preparation or wound hygiene was improved. And this could include wound cleansing, debridement, and overall taking care of the wound edge. Clinicians noted that they changed their sampling location 50% of the time. So they went to sample in a different region than they would have based on clinical signs and symptoms. Because if you do take a sample in a region of red or cyan, the positive predictive value is greater than 95%. So you can eliminate these false negative samples. Debridement was heavily influenced in over 64% of the wounds. And then I think what's most impactful here is that in 82% of the pressure ulcers, the treatment selection was changed. And so if you flip that another way, that means that only 18% of the wounds, based on standard of care assessment, would have received a treatment selection plan that was appropriate for the bacterial burden in their wound at that visit. So I think that's a very clinically significant finding. To conclude, most, 90% of pressure ulcers assessed had bacterial loads above 10 to the 4, and the median load was 10 to the 6 CFU per gram. These loads are known to be associated with complications, infection, and certainly delayed healing. The fluorescence image with the MolecuLight IX detected many more pressure ulcers with high bacterial loads with a sensitivity of 75%. And importantly, that fluorescence information modified the treatment planning in 82% of the study wounds and had a great impact on wound bed preparation even before the treatment plan was written. Overall, these findings suggest the use of fluorescence imaging facilitates more accurate diagnosis at the point of care for bacterial burden. It enables targeted care planning in pressure ulcers, a wound type in which bacterial burden is often undetected and therefore unaddressed. Thanks very much for listening. Have a great day.